Thank you. Share my screen. And I don't think we want that there, and I don't think we want that there. But I do think we want that there. So, go back. Slideshow from the start. So can everybody see that? And can everybody hear me? And, you know, as I said, I can't see the chat box. So if you put your messages in the chat box, I'll come to them at the end of this particular session to make sure that I cover everything for you. But we can have a chat as well. If you've got anything pertinent, you know, that is something that you can't move on without understanding or knowing, please just chip in. It's fine. As long as we stay on track, we'll be fine. So I wanted to really talk about pyroluria, the bigger picture today, because there is a huge picture to this. Came out of my own experience because all my family have pyroluria. It underpins a lot of mental health, chronic fatigue in everybody, underpins those with alcoholism, and I've got the whole myriad in my family. So this was really important when I learned about it. I've done a lot of work with a lady called Nikki Gratrix, who some of you will know from the chronic fatigue circuit. And over the past few years, I mean, I stopped actually testing for pyroluria because I got to the stage where I thought, I'm going mad here, everybody's got it, you know. And then one of my lovely colleagues who has 3 PhDs also said the same thing. Do you think you're looking for something that's not there? And so I stopped testing, and then Nikki came back to me about 2.5 years ago and said to me, are you still testing for pyroluria? And I said, nah, Rick. I said, I think I'm stupid. And she said, no, you're not. She said, I found another avenue to it, and I think it's really pertinent. And what she found was where we originally thought it was genetic. She's found a real strong trauma link. And that's just been, I've got it all in the first set of slides, but that's just really been acknowledged, not quite accepted, but we're nearly there. So I think most people know my background. Cardiothoracic nursing, I've always been about the heart. Despite doing everything else, it all comes back to the heart at the end of the day. I did a nurse training role for 5 years. I majored on human behaviour when I did my psychology degree. And I've had a few really interesting roles. I was head nurse and nutritionist for Damien Downing for about 5 years, who interestingly saved my life 4 years ago, bless his heart. I was course director for the MSc in Nutrition Science and Practice for 7 years, and I still tutor at Northern College and at ION. I've got 11 years here, but it's probably more than that. And I run my own international clinic where I more or less do chronic fatigue and mental health. And I can say honestly, in the last 2 years, the mental health has been the thing that's been the big decider. Since we went down into COVID, since we had the first lockdown, my patients who I wouldn't have thought were mental health patients have come back in droves, really. Like all of us, I've done a lot of the functional medicine stuff, primarily through training at college, and then I did a couple of their modules and their 5-day thing in London. But functional medicine there, I love it, don't get me wrong, but it always had a piece missing. And this really come to light when I had my own near-death experience 4.5 years ago. And I had to take a year out of clinical practice, and I never ever taken time off work for sickness before, apart from when I had a broken leg. And so for me to take a year out was like mind-blowing, but I just couldn't get well. Damien and Patricia Kane did a lot of my biochemistry for me, put me on IV phosphatidylcholine, which I was on for weeks. But there was something that was missing. And so I went back to some of the earlier work I did with Dietrich Klinghardt. And I actually trained with him in autonomic response at the same time. And Klinghardt has this beautiful model where he talks about the 5 levels of healing, and you can get this off the internet. It's all there. And he says that if we don't address all 5 levels of healing, then we can't get fully well. And when I was coming back from my near death, this is how I got well. I followed this model to the absolute T. And I was doing some of it already, but not really making the links between what I was doing and what was on his model. So he says we've got a physical body, an energetic body, which is where we hide all our emotions, or where we trap all our emotions. We've got the mental body, which is our, how we perceive ourselves, what's going on in life. And then we've got the intuitive body, which is, well, I know that, but I don't know why. And then we've got spirit body. And no practitioner can help you to heal your own spirit body. That's your own journey, your own soul's journey, and you've got to find your own way. So I love this model for that reason. There are certain practices that cover nearly all aspects of this model, and that's another thing to say. So how he works with this model is he has all the bodies on the left hand side. Then he talks about what your experience of that level is. What happens in the anatomy, or the anatomical presentation, and then the related science, the way you can find the evidence, because there's evidence for all of it. It's just that we've not been taught to look for it because we've not been in this domain. Then there's a diagnostic method, or a number of diagnostic methods in each level. And then there's a related medical treatment or healing technique that is associated with that level. What I try to do in my patients is I try to get them onto, where it's appropriate, obviously, I try to get them into a therapy alongside mine that covers as many of these levels as possible. So they're only paying for one other person, if possible. We do know that the talking therapies don't work that well for this sort of stuff. It's brilliant at certain points of time where they need a mindset shift and someone needs to help them to create that for themselves. But, you'd spend 25 years in psychotherapy, for example, to clear some of the traumas that we're going to see today. But I love this model for that reason. I relate to it all the time. And this is my gift to the profession, just to throw it in, which is going to be due out, I think, in about May. And what I've done with that book is I have done all the genetics all the way through, and I've taken each pathway in turn and gone through each snip in turn, so you follow the pathway. And then I've put a case study in there, which comes up at the end of each section in the book. But then I've also brought in Klinghart's model, and I've brought in Donny Epstein's model, because we now know that we can change our gene expression by the thoughts in our head. And so, we can kind of sit there and we can do all the biochemistry, but we'll be doing that forever, and it will cost them a bomb, and then they run out of money, and then they can't see us. And, so if we're going to help people, we have to think outside the box, I think. So this is my overview for today. Going to look at the background to pyroluria. I'm going to look at the affected groups, the etiology that might underlie all of this. There's definitely some stuff on trauma impact, because there's some brilliant studies on it. We're going to look at the triad of symptoms, and I've got a nice model that I put together, which is on a slide, but I'll send you a PDF copy that you can blow up if you want it afterwards. Just let me know. And then at the end, we're going to look at ethics and safety, because of course that applies to all of us. I guess the first thing to say is, in the 1950s, if you went into a mental health institution, and Indra might put me right here, my understanding is, from the stuff that I've read, that because of Hoffer and Pfeiffer's work, people were tested for Morph factor, and Morph factor is the thing that they measure in the urine. It came out of this work. Pfeiffer and Hoffer were working with schizophrenics, and they never believed that schizophrenia was confined to the brain. The shamanic people believe schizophrenia is people who travel both worlds, and that's quite interesting in itself. But anyway, these two people, they were the first to look at mental health holistically. So it was happening back in the 50s. They were measuring morph factor in urine and they were treating for pyroluria. I think a few things have happened since then, and there's no judgment here at all, but we've had a massive influx of SSRIs, SNRIs, antipsychotics. And then on the other side of it, we've also got a test here that some people don't believe. Some people don't even believe the diagnosis exists, and I'll give you a link to that as well. But also, these tests, they've not been through double-blind placebo-controlled trials. So how are we ever going to get people to accept them? And with this one in particular, it's like a lot of tests. Once the morph factor is exposed in urine to heat, light, and oxygen, well, the morph factor, or pyrols, whatever we're going to call them, they start to deplete. So you could, if your sample is sat in transit 2 or 3 days because it's got stuck in somebody's postage van, then it might come back a false negative. So we've got all these issues to contend with, which kind of takes it off the radar. So, you know, there's no, like I said, there's no judgment with any of this, but they're kind of facts of life. So what is pyrrole disorder? It basically is a disorder of hemoglobin synthesis. It presents as this morph factor in urine. It's got a number of names, and you have to go into the research and type in every different name because there is no standardization with it. Whoever is dealing with it is going to say, well, this measures the best. So cryptopyrroles was the first kind of name that it got. And then some people said cryptopyrroles is not the exact thing to measure. You should be measuring hydroxyhemopyrrolin, or some people call that hemocryptopyrroles. And so at the minute, we've got a bit of an argument going on with this as well. We have the closest lab to us is in Holland, the KEAC lab, and that's just an acronym, KEAC, and I couldn't pronounce the name to save my life, but it's an allergy lab. And what they do is they measure the HPU, and they do 2 different tests. They do a basic one and they do a 24-hour test, which is probably going to be a lot more accurate because you taking a 24-hour urine specimen and then you're just decanting 10 mils and sending that off. And again, with the testing, the idea is that you do the test at the time when the person's most stressed. Well, try and get a child who's having a meltdown into a loo for a pee. That's a big joke, isn't it? So, and there's certain times of the day when we're more stressful, and the cardiac research tells us that because more heart attacks happen at 5 a.m. and 5 p.m. You know, because that's when people are more either waking up out of their sleep and their blood sugar's in the floor, so they crash, or they're in rush hour traffic or thinking about rush hour traffic. So I mean, they're not the only reasons, obviously. But so that can set things up. But I will say, I worked with Mark at Biolab for quite a while when we first started doing the genetics work. And I asked him about this because I really trust Mark. He's a good guy. And what he said to me was, give me, I'll send you 20 kits. Every next 20 patients that you send their 24-hour specimen, just decant one into mine as well, and let's do a comparison study. And I know they're both measuring different things, KPU, HPU, but Mark said there's actually virtually no difference. And when we did those 20 studies, they were all identical. There was one that was out of alignment out of the 20. So from that point, I have just done the Biolab test because it's nice and cheap. It's £49, I think, as opposed to 100 and odd for the KEAC test. Plus you've got to pay for the courier, which is not cheap. If there's somebody I'm really unsure about and I need to test, I might send them for the 24-hour test, but it costs a heck of a lot more, something like 4 times more. So I try not to do that if I can. So that's the thing with the testing. Trudy Scott is probably the world leader. She was the one who wrote the anti-anxiety handbook, anti-anxiety solution or something it's called. And she was the one who really brought pyroluria to our attention a number of years ago. If you live in Australia, everybody in Australia seems to have it. It's, you know, they've got so many pyroluria supplements, it's untrue. It's like, you know, they test everybody for it. And over here, it's kind of, you know, it's just one of those things. But maybe that's because everybody needs B6 and zinc as well. So genetics, it all came from Trudy Scott, and now we know that it can be acquired. And this is more Nikki Gratrick's work, but, you know, she's kind of putting the energy, she's putting it all together from other people. So what about the synthesis then? So as I said, it's a blockage in heme synthesis. We all know that heme's the iron containing component in red cells. And this blockage in heme synthesis leads to higher levels of HPU or KPU in the urine. And what that does is it binds to aldehydes. And the biggest aldehyde out of all of these is B6. So it predominantly binds to B6, drags B6 out of the body, but then because all of these other, in particular zinc, these are all synergistic nutrients with B6. They all get pulled out as well. And it's either because they're a synergistic nutrient or the B6 and zinc provide the enzyme support for these pathways. So they provide the enzyme support for hormones and neurotransmitters and detoxification, which we'll go into in the second half. So you lose all of these nutrients when you've got pyroluria. So the genetic side of it, as I said, was Trudy Scott's idea. And what Trudy says is she's got her own questionnaire on her own website. I think the website is called Every Woman Over 29. So she's got a certain subset that she's looking at. And she told us that it happens in the female line of the family. So if you diagnose, in inverted commas, one person in the family with pyroluria, you probably find that nearly every other female in the family has it. And so what she kind of looks at in her questionnaire is, have you got sisters and are they all like you? I don't see that, if I'm honest, at all. I might have done in the early days when I was looking for it, but and what I see in my patients is they'll see it in themselves because the questionnaire from Kiak is so thorough that they'll just see it before they even get the score. And then they'll say, but my mum had alcoholism and my dad was this and this person was this. So they're kind of doing what the autism spectrum people do, is they're finding pockets of people in their own family as opposed to seeing a whole genetic trail. So I mean, don't get me wrong, there will be those trails where you see all the females. But I think the overriding thing is this pale China doll appearance. And you see this loads in the autistic kids. So, and I didn't say, actually, I should have said at the beginning, grateful thanks to Nikki Gratrick's, because since I've been working with Nikki Gratrick's really closely, I've been able to put a lot more pieces of this puzzle together. So some of the slides I have kind of said, this is Nikki's slide and thank you. But I think it's good to give her the praise for she deserves as well. So this is Nikki's work and what she's looked at. And Nikki, for those who don't know her, Nikki, when we left ION, because we trained at ION together back in 2003, when she left ION, she went to open the Optimum Health Clinic, which, as we all know, is one of the biggest in the world now, looking at particularly chronic fatigue. And she opened it with her then partner, who's the psychologist who runs that half of the clinic. And she's gone on to bigger things now. But this is where a lot of this work's come from, because they did one of the landmark studies on chronic fatigue that got into the British Medical Journal. So what she's looked at is she's looked at, you know, nearly every patient they've had has had some kind of trauma in the background. And so they started to look at trauma in a big way. And what we do know is PTSD is fairly rare. Oh, we think it's fairly rare, but I think we just haven't been switched onto it, maybe. Or, you know, that we have a lot of negative thoughts about the psychology of life as well, don't we? But if you look at PTSD as a diagnosis, it's a reaction or a trauma response to a discrete event, such as a car crash or an assault or a war zone. And what the evidence shows us is when we have a situation like that, and let's say you're in a car, you're just going for your takeaway with your husband, and you're on a single track road, and coming in the other direction is a car coming at great speed, 100 miles an hour in a police chase. And you know you're going to hit them head on. You can't avoid the accident. There's no way you can even pull off, because you'd end up in a ditch and dead anyway. And so what happens is, just before that impact, what the body does is it shunts that trauma response into the amygdala, so that you're not continually traumatized by it. It's our mechanism. And so that's a discrete event. We might not get to that through a talking therapy, because you don't have the memory of it, because the brain's just shut it out. And so, yeah, you can spend years with a trauma therapist and not get anywhere, but EMDR is absolute magic for an absolute cure for something like that. And that's even available on the NHS now, which is great news, to be honest. It does take about 10 months to get a referral, but then, you know, not anything is worth waiting for, as long as you're not dying under the strain of every other trauma that you've got. So PTSD, that's a one thing. And then what we've got now is we've got what we think is an endemic attachment and developmental trauma. Ross Rosenberger will come across in a bit, is the king on this, and it's coming from adverse childhood events, and that came from a huge study, which again I'll talk about, Kaiser Permanente study, where they looked at adverse childhood events. We actually think this is a silent epidemic. It causes chronic autoimmune dysfunction. And then we get this label, complex PTSD, which is where you've maybe had one trauma, and then because the trauma's stuck in the amygdala, you're emotionally challenged all the time, because without your conscious awareness, because you haven't got the memory of it, you get into scenarios or you get into emotional situations, and that trauma keeps lurking its head. And so then you get a person who is in a constant anxiety status, and they might get a GAD diagnosis. And this is the stuff that's endemic. And up until now, we've never really appreciated it. We just go, well, that's stress. And then on the other side of that, we go, well, I'm not stressed, because we all live like this. So this is really big stuff now. It's really cutting edge stuff. Whoops, why won't that move? So we have to consider that will have an impact, or the impact of that trauma will have some impact on the psyche. When you've had adverse childhood events, they don't even need to be big ones. Just a really simple example is, we all think of traumas as something catastrophic, but let's imagine you're a mum, right? You've just had a new baby and you're trying to you're breastfeeding that baby. Your 2-year-old has just somehow unhooked the baby gate and he's running into the kitchen where you've got a pan of hot water bubbling on the stove, and he's running straight to it to get the handle. You can't get there in time. So what is your immediate response? Don't go near that pan, you'll get burned. That can leave an imprint on that child that's with them forever, and put them in a situation where they're afraid of pans, afraid of the cooker, afraid of running into the kitchen. And it's all been done very innocently. And we never know that, because we're all preconditioned up to the age of 6, where we're just sensory beings, and we're all kind of working in this social soup. But that can be, to a sensitive child, that can be massive. So, as I said, it can lead to negative emotions and beliefs about the self. The inner child can feel really lost and alone. And, you know, I'm sure you've all had patients like mine who sit in your office and go, I don't belong here. I don't belong in my family. I don't belong here. I don't belong there. And it's fascinating stuff to uncouple. That also leads to a lack of sense of safety. And then with the lack of safety, there's no ability to self-soothe. And we all self-soothe: music, you know, singing, gargling, Epsom salts bath, you name it, we all do it. But they lose that ability to do that. And what we see in the autistic kids, which is where I kind of observe all this, we see them arm flapping and rocking and head banging and doing all that. And it's, you know, it's all kind of self-soothe stuff. It can also lead them into a situation of self-hatred, and then that can bring on rage and anger. And the rage and anger is always a reflection of fear. So despair and hopelessness can underpin all of that. And then, of course, if you've got that as your starting point in life, that impacts every relationship and every job success. And so you get these people who just can't achieve at anything. You know, they stay in a job a few years, or, you know, they're preyed upon by people who are stronger in personality, shall we say. And so the idea around that is that a childhood trauma-induced trait can become a trait which becomes your biological fate. And unless you do a lot of personal development work, you might not even get that phrase, but it is there, and it's in this infant mental health journal. So you can go and look at it for yourself. So what about the Kaiser Permanente study that I talked about earlier? This was a study done in 1998, and they looked at 17,500 adults, so a massive study. What they did was they categorised what they thought were the 10 adverse childhood events that were more likely to happen to the under 18s. And so things like parents separating or divorce, physical, sexual or emotional abuse, physical and emotional neglect, domestic violence, mental illness in the family, substance abuse, or incarceration by a related family member. So they looked at all of those. This study took that a little step further, a bit later on in the year, and it compared the relationship of those particular adverse childhood events and household dysfunction to many of the leading causes of death in adults. And that just, you know, it's mind-blowing stuff, really. This is from that particular study, and these are the mechanisms by which adverse childhood experience influence health and well-being throughout the lifespan. So you've got your historical trauma that might be your and this might be birth, or it might be birth trauma, or it might be being born to a mum who's got depression, or a mum who's an alcoholic, or, you know, and so you've got attachment trauma as well. Then you've got your social conditionings, which comes from kind of locally initially, but then the wider picture, school, church, you know, all that kind of stuff. Then you've got adverse childhood experiences that occur as part of all of that. And then that is said to disrupt neurodevelopment. On top of, and then what comes out of that is social, emotional and cognitive impairment. I'm sure we're all seeing that every day, or aspects of it. And then some people go on to develop health risk behaviour. So they'd be the alcoholics or the type A personalities who want to be bungee jumping every week. And then that leads to disease, disability and social problems. And then the early death, there's a 20-year reduction in lifespan for these people if they've got more than 4 ACEs, I think. So yeah, the impact of adverse childhood events, 67% of all adults have been exposed to early life stress. That's huge in itself, isn't it? 80% of those to more than one. There's a dramatic increase of 7 out of the top 10 causes of death with a high exposure to adverse childhood events. And then there's a 6-fold increase of illness like chronic fatigue with any adverse events. And then, as I said, the 20-year reduction in lifespan compared to those without ACEs. So this alone just says, you know, we need to be more aware of what we've got going on here. Bessel van der Kolk, I love Bessel van der Kolk. He's one of these, the body holds the score, or when the body says no people. I've got some books on one of the slides that you can kind of go to if you want to take this further. But what he said about the adverse childhood events study, it was a nice superficial study on a huge sample, but because of the size of the sample, they had to ask particular questions, which meant nobody was interviewed. And so while they were looking at those huge events, they missed all the subtleties of what really happened to people. Once you've had a traumatic event, and if it's in a family, if it's a family event, then everyone's reactions are going to change and everybody's going to be on guard. So all the behaviour structure within the family is going to change. That's going to cause dysfunction in some families, which is going to exacerbate that one trauma. So that's when we start to come into the complex PTSD. So what he's saying is, whilst that is an amazing study, it is just the tip of the iceberg. So this paper takes that a step further, and it talks about the unprocessed indirect signs of post-trauma. In particular, it's looking at transgenerational trauma or intergenerational trauma. There's kind of 2 ways to look at this. It looked at 3rd generation after the Holocaust, and they found the trauma impact in those people. You know, you can relate that to us today, particularly maybe my age group, maybe not so much some of yours who are kind of 30s and 40s, but it's still there, but you won't be aware of it. But like my generation, my dad was in Malaya for 3 or 4 years. They were all conscripted. They all had national service to do. He went out to Malaya and Egypt, so he fought out there, and my dad was the biggest empath. I can't imagine him sitting in a thing with a gun at somebody else's head. I just can't. And most of us will say that about our parents, I guess. But then we've got, before that, we had First World War. So he grew up in the First World War. He went to school just as it started. So he's got trauma from that. And then his dad before him, he was in the First World War. So he got trauma from that. You know, and it's all those kind of things that right now, at this point in time, a lot of people are seeing in our autistic kids, for example. Klinghardt would say we carry at least 4 generations of transgenerational trauma, and it's coming through the behaviour, because up until now we've never really accepted any of this. And so right now we're starting to go, what the heck is going on here? Why are people so anxious? What, you know, because we're seeing the effects on biochemistry, because people like us have come to this side of the health fence and said we need to look deeper. And so we're kind of, I think, pushing the research. So it's interesting. 4 generations is what Klinghardt originally said, but I read a paper recently that said they can carry as much as 14 generations, which is fascinating. So look at the relative risk factors. For 4 adverse childhood events, that can increase the possibility of chronic obstructive airways disease 2.5 times. It can increase by 2.5 times the incidence of hepatitis, 4.5 times for depression, 2.5 times for cancer, 1.6 times higher for the risk of diabetes, 2.6 times higher incidence of stroke, and 12 times higher the incidence of suicide. I don't know about you guys, but I'm hearing a lot about suicide at the minute. Maybe not so much now, but certainly last year, and certainly in the autism spectrum, schizophrenia population, where they didn't get as much support. But yeah, it's interesting, I think, to look at these, because if you look at all these conditions, the underlying etiology for all of those that we would see biochemistry is methylation. So this is really screwing up methylation big time. If you have 8 ACEs, that's going to triple the risk of lung cancer, 3.5 times the risk of heart disease. And of course, these are the top 2 killers in the West. So always worth thinking about, really. Again, this is one of Nikki's. With chronic fatigue, we know that there's a massive correlation between the female and autoimmunity. We know that it's much stronger in the female. We also know that the correlation of autoimmune risk in women with adverse childhood events is as strongly linked as smoking is with cancer. So that's interesting in itself. Can you mute, please? Okay, I think I've got it. Right. Okay, so back there. Oops. So how does childhood biography become adult biology? Let's look at that. Now, this is Ross Rosenberg's work. Again, this is Nikki put me onto Ross Rosenberg. He's an amazing guy. He's got a website called selfloverecovery.com. He's a psychotherapist, really clever guy. And he has put together this parcel of work that it's just amazing, really. He says that those with attachment trauma, particularly, I've got something called vitamin L deficiency, which is self-love, basically. And what he focuses on is helping people to love themselves, because if you can't love yourself, you can't give love out, can you? It's kind of almost a false thing. But he's saying with vitamin L deficiency, that leaves a neurological imprint. Energetically, it also closes the heart. So not only can we not give it out, but we can't receive it either. And this again is fascinating work. It also leaves an energetic blueprint. So he's really hot on this. And, you know, if you're interested, just go and have a look at his work. So how does this impact on biology? So early life stresses lead to epigenetic changes. They lead to aberrant gut function, so we get a gut health decline. They lead to cell danger response, which is Navo's work. If you haven't come across Robert Navo, I would definitely read his landmark paper on cell danger response, because if the cell doesn't work, nothing works. Thank you, Jess Armine, for that. But it's a great paper. It's really easy to read. It puts everything, you know, really nice and simple. Also, early life stress disrupts hormones, because it's going to disrupt your blood sugar imbalance, and then your insulin's going to upset all your other hormones because that's firing too much. It's going to affect your detoxification, because you need B6 and zinc to open up your transsulfuration pathway, and if that's not happening, you can't detoxify, so you get the pathological detoxifier. Also, because heme's needed for your CYP enzymes, you get pathological detoxification between phase 1 and phase 2. So loads of problems with it. And it impacts on the immune system. And given all of that, I would say, well, is that not pyroluria? And you'll see when I give you my my diagram, you'll see why I made that connection. This paper looked at, as I said before, about methylation, stress affecting methylation. This looked at associations between early life stress and gene methylation in children. And what this study highlighted was that at a certain point, a critical brake is switched off, and then the child's marinating in stress hormones and inflammatory cytokines from a young age, and then they have lowered threshold responses to stressors. Well, is that not autism spectrum? Because that's exactly how I see autism: a body that's inflamed, methylation that's switched off, hormones that are all over the place, and a child that's just completely shut down in the worst case scenario. But even the Asperger high functioning kids, they're kind of in a bubble. It's like, I'm not safe here, I'm not safe in this world. And I think it's just fascinating. So that's kind of the trauma. If anybody's got anything burning they want to ask, feel free before I move on to the biochemistry. Okay. So what about heme then? Obviously it's needed for liver detoxification, as we all know. It's a supporting nutrient for all the CYP450 enzymes. So if we don't have enough heme there, they're all firing on all 4 cylinders. It's needed to create cystathionin synthase, catalase for metallothionein, guanylate cyclase, sulfate reductase, nitric oxide synthase, and pyrolase. They're all needed throughout, the body for various things, but detoxification, support, antioxidant support. And as we said earlier, the HPU patients lose supraphysiological amounts of zinc, B6, biotin, and manganese in the urine. So without that, no systems are working. Morph factor, we've talked about it's the morph factor that we were originally calling this. There's a clear relationship between elevated urinary HPL and psychiatric symptoms. And that's been demonstrated by, and these were really early studies as well, non-psychotic psychiatric patients, there's a 25% increase in elevation with those. Chronic schizophrenics, 50% increase. Acute sudden onset schizophrenia, 75%. So, look at your trigger, what's triggered that? And then the controls, nothing. So quite interesting. And this was Hoffer's work as well, starting to use niacinamide to correct the morph factor. I'm not finding that is as effective now as it was for them then, because I find if you give too much niacinamide and you've got someone who's not methylating well, then you're going to mop up all their methyl donors. What I'm finding is glycine works better, because glycine actually goes into the methylation pathway. And whereas niacinamide would mop up your methyl donors, and then you might swing between having enough methyl donors or having too many and not enough, because niacinamide goes in, does its job, and then you just pee it out. Whereas the glycine goes in, does whatever the job it is, and it balances by staying in the methylation cycle. I'm trying to think who was the person who brought that to my attention. It's one of these self-help guru things, people who does the genetics. It might have been MTHFR support. So anyway, the nutrient depletions, they end up with a double deficiency of B6 and zinc. As a result of that, they end up with a depletion of dopamine, GABA particularly, and serotonin. Of course, we're not supposed to recommend GABA here because it's outlawed. We can buy it at Amrita. But yeah, we're a bit stuck with it really. It also leads to depletion of glutathione, metallothionein, cysteine, sodase, catalase, as we said on a previous slide. The supplements of B6 and zinc might normalise HPU levels, which often results in elimination of symptoms and the need for psychiatric medication. Depends how old they are, how quick it's going to take, etc. And we'll cover that by the rest of today, so don't worry. So some common abnormalities with pyroluria. We often see a high low density lipoprotein, low HDL. We often see a low normal alkaline phosphatase because that's a measure of zinc anyway. We often see low white blood cells, low omega-6 on fatty acids, cell membranes. I have to say, you know, there's so many tests out there for fatty acids, but the only one, and I'm still using them, the only one I use now is Kennedy Krieger, because I found that I've done 2 or 3 for different people, and they've all conflicted each other. And I know that Kennedy Krieger are the leaders for the epilepsy research. So, and I also know that Body Bio do an interpretation of that particular result, and you get a beautiful report out of it. It's more expensive, of course, but you know, when you need fatty acids, I kind of think I need to do the best one I can, really. So I use them, and they always find low omega-6 in these people, and that's because we use omega-6 because the cell membrane is a 4-to-1 balance of omega-6 to omega-3, and the cell membrane is all fat, and the body stores all the toxins in fat. So a lot of it is on the cell membrane, and they use a lot of omega-6 to do that detoxification. We also see high MCVs. We see, not that people do bone biopsies often now, or cerebrospinal fluid, but we see low manganese and low zinc in those as well. So they're all really good indicators. We also see severe zinc, manganese, calcium, magnesium and molybdenum on bone biopsies. P5P is needed for zinc, manganese, magnesium and chromium absorption. So, and that's just a starting point, really. It also produces niacin from tryptophan, which explains in some ways why niacin might not be the thing of choice to balance this up if, you know, if it's going a bit to pot, really. So this is the diagram that I put together just from my personal thing. And how I work with this, I go from pyrrole disorder and then I go up each colour. I give this to all my clients. You know, if they've got a positive test, or you know, a really high score on the KIAC quiz, I'll give them this, because 9 times out of 10, if they're older, they're suffering all of this anyway. Because all this stuff, it's all GI, leaky gut stuff. All this is all functional zinc deficiency leading to immune regulation, and then memory, concentration stuff. And then down here, it's all fatty acids. You know, so I just think it's easier than writing a reams of report for them. And it means my report can be brief. I also do a recording of my consultations as well, because I like to empower them where they can accept that. So physical signs and symptoms you might see. You might see white spots on the fingernails. You might see an unusual fat distribution as well. Some of them have loads of fat on tops of their arms, or just in strange places around the knees and stuff. It's like the body's just depositing fat in different areas. You often see stretch marks, particularly those who've kind of had a weight problem before. You always see them kind of on the tops of the thighs. You always see them from side of the abdomen. I don't think they always have the pale skin, but you will find that they'll probably say to you they can't go in the sunshine because they burn. You know, they're the ones that blister and burn. They often have a sweet, fruity breath, and they often are very aware of their own body odour. very aware. And some of them, and I remember this happened to my son as well, some of them, they take to sleeping in t-shirts because they detox overnight through the skin, because obviously the detox mechanisms are not working. So they get into a sweaty state at night, and they start to detoxify, and everything just goes grey because they're throwing out all the heavy metals overnight, if they're lucky enough to throw out the heavy metals, that is. But yeah, they get really stained clothing. They nearly always have overcrowded teeth, coarse eyebrows. Some of them have a real poor appearance of tooth enamel, and some of them actually come in with teeth, dental demineralization. That's one of the things I see in the kids quite a lot, and that would certainly lead me to look at, is this pyroluria? Creaky knees, we always say creaky knees, manganese, don't we? It makes sense. They've always got cold hands and feet. Stunted growth. Again, mine presented really stunted growth. Their dad's 6'2", and I'm 5'9", 5'10", and the kids at 10-year-old, they looked like 6-year-olds, but they were fat, and neither of them were fat at birth, but they just were stunting and growing out instead of up. And when I put them both on a gluten-free diet and gave them some zinc, within a year they shot up to their normal size, and the pair of them now are 6'3" and 6'2". So you know, it's quite staggering how much how much growth is stunted. We often see dystonia as well, so lack of muscle tone. Neurological symptoms, anxiety is always there, even if they suppress it, even if they have just got to the stage where they can't cope with anymore and they just shut down. And this is what I think autism's this, without a T, without a word of doubt. There's always an inattention, nervousness, and certain genes will push that even more. The BHMT gene will push it, the GAD gene will push it, and certain HPA axis genes, they just help people to internalize their own stress. And of course, their environment will do that as well. We often see pronounced mood swings. So this is the person who has the regular meltdowns. They often report low stress tolerance. They can often as well notice that when they're in different situations, the stress tolerance is different, depending who they're with, where they are, etc. They often present with depression, panic attacks. Yeah, they might not recognize them as panic attacks. It might be the typical low blood sugar, 3 o'clock in the morning, where they get up and they have a drink of tea and then they have to go straight to the loo, and they're not appreciating that that's anxiety either. So, you know, sometimes they need a bit of educating. Most of them have got poor dream recall. Some people relate that to the B6 deficiency, but to be honest, I don't see a big correlation there. So I tend not to say to them, take the B6 to your dream recall, which I know Trudy Scott does, because you can overdose with B6 as well. And then if you push too much toxicity down that transsulfuration cycle, it's as bad as not enough, because they've gone over the Gaussian curve. They often complain of memory loss because of course in methylation they've got to make acetylcholine, phosphatidylcholine, and if they're low of acetylcholine, they're going to get memory loss. Some of them present with seizures, and I think the latest figures on the autism spectrum people were 30% of those develop seizures. They often complain about tremors, hand tremors. They often complain about knee and leg pain, which sometimes if it's a child, it'll get put down to growing pains, but usually that's manganese deficiency. They often complain about burning, crawling skin. And I don't know, in the last few years, we've had a big splurge on Morgellons syndrome, because they're the burning, crawling skin types as well. But I also think, well, this is an adrenaline reaction. Again, it's the low cortisol person who's pumping out adrenaline when they're going into fight or flight, and then the skin's like, you know. They often report neurological pain as well, and mostly hypersensitivity to light, sound, smell and touch. Well, is that not our autism spectrum? Absolutely. Digestive symptoms, motion sickness is big with these people as well, because their balance is all off. They often report early morning nausea and they're not pregnant, but of course that might be low blood sugar, that again they're not recognising because they don't have that level of awareness. They often report abdominal tenderness, and these are the people who might come and visit you in a shell suit because they want something that's really easy and stretchy and, you know, doesn't cause any strain around the belly. They often won't wear things like jeans because they're too restrictive. They often report constipation because B6 and zinc help you to create stomach acid, and if your stomach acid levels are low, everything's going to be sluggish from the top down. They often have cholecystokinin feedback loop failure. So I look at the digestion in a big way, as I'm sure you do. If the stomach acid is low, you're not getting the hormone, you might not be getting the hormone trigger to trigger bile flow when they've got fat in the diet, or pancreatic flow, and of course you need your bicarb and your digestive enzymes there. And if you've not got that going, you're going to be prone to SIBO, you're going to be prone to constipation because of course bile flow promotes peristalsis. You're also really prone to lectin intolerance. And again, there's not really much out there on lectin intolerance either, apart from Grundy's work, and some people are dissing him now. But I found quite a lot of my people, I've had to take them off lectins completely until we get all this sorted. It probably takes 3 to 6 months to do that. But I just find they just react to everything that's got lectins in. So they're the people who can't do the nuts, can't do the grains. They've got usually got massive histamine intolerance as well. So gluten is only part of that picture, but obviously it's a big part of that picture. They often present with anemia, and that can be long-standing anemia, or in the females it can be, if they've had children, it can be anemia during pregnancy, because that's a time when we use a lot of iron. They're often sensitive to medications and supplements, so you know that goes without saying. And they nearly always have intestinal hyperpermeability. Again, it goes without saying, really, it's part of the course. Hormonal symptoms that you might see, acne is a biggie. Irregular menstrual cycle. I very rarely see anyone who has not got an irregular menstrual cycle, or who, you know, if they're kind of post-menopause, they've struggled with hormones all their life and now suddenly they've got no estrogen and they feel great, or they've had masses of estrogen, they've not lost it all, it's all in the belly. Maybe that's the other side of it. Or I see them where they haven't had any hormone problems to speak of, but they've taken the pill quite a lot during their life for obvious reasons, and then they've hit menopause and they need an HRT and God knows what else to keep them alive, you know. So you do see it somewhere, and in those who swear they don't have any menstrual cycle irregularities, you'll see HPA axis dysfunction. So it's got to be somewhere. It's just a matter of being clever enough to look for it. We often see infertility in these people as well. Sometimes we see a delayed onset of puberty. Haven't necessarily seen anybody who has an early start to the menstrual cycle. And of course, dysglycemia goes without saying. Nearly everybody on the planet's got dysglycemia and letter C and O's, haven't they? So conditions associated, lots of them. ADHD, alcoholism, autism I've spoken about. Bipolar disorder, criminal behaviour. There's some really great studies on criminal behaviour. Just I can't remember who did them, but they were standing in jails and they had all the inmates in the place where they do all their exercise outside, and they were asking them certain questions about did they have this kind of ACE in their thing? Did they have this diagnosis? Did they have that diagnosis? And then they were just getting them all to have a step forward. And there was about 2 out of, there must have been maybe 100 people in this big circle. There's about 2 that stayed back a bit. Everybody else was like cuddling by the end of it. It just showed you how they end up in these places. Down syndrome, you can see pyroluria in Down syndrome. You wouldn't think so, would you? Because the Downs kids, they're all the lovey-dovey kids, aren't they, that you don't think have got any stress at all. Epilepsy we've talked about. Heavy metal toxicity goes without saying, really. If you can't detoxify and you can't use your sulfation system, then you're going to have heavy metals. And if you're going to be this nutrient depleted, then you're probably going to be depleted of a lot of other minerals, because they're going to be trying to, you know, make up the reserve. Learning disabilities, definitely. Lyme disease, there's some studies on Lyme disease and pyroluria as well. And I think Klinghardt drove some of those, but obviously Klinghardt doesn't necessarily publish his work. So you only kind of see it on his website. Multiple sclerosis, there's pyroluria links there. Parkinson's, of course. Schizophrenia we've talked about. Substance abuse, well, if there's alcoholism, there's, you know, substance abuse is the next thing. But I think the alcoholism is, I think it's more direct, because alcohol obviously contains GABA. So sometimes you get the alcoholism to give the GABA initially and then to dull everything. So what might be the triggers? Poor genetics, of course. Environmental toxicity, we've got tons of that. Adverse childhood events, trauma. And that can be one discrete trauma that's just too big for the person, or as we said before, it can be ongoing. Chronic infections. We see loads of people, don't we, with chronic yeast, chronic microbial infections, chronic viruses, Epstein-Barr, herpes simplex. They're all kind of wonderful, aren't they? And all of those things are highly aggravated by chronic stress, because they're all going to produce injury, oxidative stress, which then leads to chronic and debilitating illness. So there's quite a lot there to kind of look at and say what's in the timeline for this person, and then just identifying what are the key ones for you to feed back to them, because then if they've got the key bits, you can help them to move forward with whatever therapies they need. This is Klinghardt's protocol. I have to say I'm not a person for protocols at all, because I just think people are so different and people react so different, and unless you've done all the genetics and the most amazing timeline and you know everything about that person, well, you can't predict how often how people are going to react. And sometimes the people who you think will do the best will actually fall over with the first capsule, and vice versa, obviously. But this is kind of Klinghardt's overview. He reckons zinc 250 milligrams daily for 3 to 4 months. That's a whacking dose. I have taken it myself, I have to say. If you recommended that kind of dose for somebody for zinc, I mean, obviously you've got to watch it because you're going to deplete copper. And whilst, you know, we taught in the forums on Facebook, etc., which is where a lot of these people are coming from, they talk about copper dumping. I kind of don't necessarily think about copper dumping, more heavy metal dumping, because everything will come out once you start putting the zinc in. So you've got to be really careful with that, I think, and especially at that dose. But what Klinghardt says about zinc is, if you get someone onto this kind of dose for zinc, maybe even not as high as that, but if you find that you can't get them off it, either for their own fear or because they just feel ill when you start taking them off it, you really need to look at viral load, because zinc is such an antiviral that if they've got an ongoing viral load that has not been addressed, then they won't be able to get off the zinc. Obviously, it gives manganese, and then he gives micro minerals, and he does that to alkalize the body again, because it's going to be acidic in this state, and B, to get rid of the heavy metals. Biotin stops yeast migrating to mycelial form, but it's also really good for a lot of these people lose the hair as well. Chromium he gives in addition to everything else because of the blood sugar management issues. And then his B6 he uses a combination of P5P and then pyridoxine hydrochloride, and he takes it up to 800 milligrams. Well, again, that's a whacking dose. Most of us, if we were given 100 milligrams, would be thinking that's like catastrophic. But these are the levels he's given over the years. Magnesium glycinate, I do love magnesium glycinate, and I use a lot of that. I really do. He also gives niacin. Sometimes I do, sometimes I don't. I do love taurine. Taurine's obviously really calming for the brain. If the transsulfuration cycle is not as effective as it could be, then the patient's probably not making taurine, so the bile's going to be sluggish. And this is all Patricia Kane's work as well. She's avid about getting the gallbladder working massively. So yeah, taurine can be amazing. And not forgetting metallothionein. And who does this work? Morley Robbins is the person who's really hot on all this stuff. He's the, now what's he called? He's the magnesium king. I can't remember what he calls himself, but he works purely from hair mineral analysis. But he does it in such depth, and he's got his own test that does metallothionein, all the ions, TIBC, etc., and red cell magnesium, and then he puts that with his hair mineral. But he talks about the homeostasis of copper being fundamental, and actually I think Sarah Myhill is in that, not with him, but she's in that kind of framework as well, because she seems to give copper to nearly every patient. Morley would say you've got to be careful about the type of copper that you use, because a lot of the copper supplements don't work, which we know. But anyway, copper's needed for pruning, for growth and inhibition of brain cells in early development. It prevents mercury and other metals from passing across the intestinal and blood-brain barriers. It's important for immune function. It supports the DBS enzyme as well that converts dopamine to noradrenaline and adrenaline. So really crucial there, because some of these people, if they haven't got copper there, they'll trap dopamine, which puts them into suicide ideology. And of course, metallothionein functioning can be disabled by severe oxidative stress. So interesting stuff. Some possible comorbidities, obviously blood glucose dysregulation goes without saying. HPA or HPT axis dysfunction or both would go alongside this, so you might need to support that. Dysbiosis would definitely go alongside this. You might see celiac disease or non-celiac gluten sensitivity with this as well, for definite, because obviously gluten is one of the hardest things to digest. How many times do I see cholecystokinin feedback loop? I would say in the elderly, more elderly, over 50s, I would say nearly all of them have cholecystokinin feedback loop abnormalities. And you often see depression and anxiety as a comorbidity as well. So, you know, the person who comes into your office might be diagnosed with any of these, pre-diabetic, you know, they might have already had NHS tests. I'm getting quite a few of mine are coming through who've had synaptin tests, and how they're getting those when the NHS is on its knees at the minute is anybody's guess, but they're obviously getting through somehow and getting these tests done. So something's working, isn't it? There are some cautions to consider. There is a need to understand the detoxification pathways and how they work, and especially the sulfation pathway, transsulfuration pathway, because obviously the CBS enzyme is dependent on B6 to open it. And so if they've been B6 deficient and homocysteine's high and everything's stuck up here, the minute you open this up with B6, if you're not looking at all of this and if you're not managing all of this, then you might get high ammonia. You might get everything stuck at cystathionine, because if you haven't got enough zinc, this one might not work either. You'll be low glutathione, so you'll have a whole load of stuff stuck here. You might push it down here, and then if they've got a SNP here, they might not make taurine, so everything then gets stuck here as well if the SUOX enzyme's not working. And actually, for those of you who are doing genomics, I find this enzyme very rarely comes out as a SNP, but the gene very rarely comes back as a SNP, but the enzyme's not working. And you can see that because they've got a high level of sulfite sensitivity. And so I still work with this more than anything, to be honest. But we'll talk about that as well. I think the safety and ethics thing around all this is pyroluria is not just about B6 and zinc. There isn't a standard protocol. And as I said, you need to understand detoxification, particularly transsulfuration, because not only is that detoxifying all the internal toxins and the external toxins, it's also sulfating things like vitamin D, hormones, neurotransmitters. And if you're not sulfating them, they can't work anyway. So you need to make the sulfate in the first place. Plus, it sulfates cell membranes. And if the cell membranes don't have sulfur, they all stick together. So then you've got red cell clotting. And we see that on live blood cell analysis every day. I think the older they are, the slower you have to take it. There might be a lot of hand-holding with these kind of patients, but it's not for long, to be honest. So, you know, before you go away today, don't think you've got to have them ringing you up every 2 minutes. Some of them will, because some of them will be so anxious it's untrue, and they'll wear you out with their anxiety if you let them. But one of the ways I do this is I educate them as much as I can, as much as I think they can take. I give them the diagram so they can understand what, you know, just look at that to the heart's content and try and educate themselves to their own level. But then I do things like, I might do like a weekly catch-up. I leave a Friday afternoon for weekly catch-ups, and I might just talk to them for 15 minutes every Friday. And it might only be, it's not counselling because I'm not a counsellor, but it might just be just a check-in to keep them psychologically sound. Well, you're doing this and that's fine, you know. Just do a little bit of this. So there might be a bit of diet tweaking. There might be a little bit of just, you know what, you're doing great. It's okay. That's what we expect at this point in time. And sometimes just by doing that once a week, and then I just charge them for a follow-up consultation at the end of the month. So I do it on trust as well, because I just think these people, they just need as much support as we can give them. And especially if you're giving them B6 and zinc and you've seen the changes quite quickly, which you might, or if they need betaine hydrochloride for stomach acid, then you've got to be prepared to support them through that, I think. So that's my hand-holding bit that I do. So anybody got any questions? Anything that I've, chats. Hang on, let's have a look. Totally resonated. Okay. You told me if there are the symptoms and negative tests, treat as if they, yeah. So yeah, Sylvia, and that's the way I do it. Sylvia says he told me if there's any symptoms or negative test, treat as if they have it. Yeah, I totally agree with that. What I do is I'll give you the link is on the slides, but I get all my patients, I do a free 15-minute introductory discovery call, I call it. And then at that discovery call, I work out, is this patient really anxious? You know, are they ready for what I've got to offer? Do they actually need somebody else rather than me? And I do all that at that 15 minutes, and then I'm just honest with them. But at that point, if I pick up anxiety, or if I pick up, I let them tell me a bit, but I don't let them give me the full story, because they can go into it for hours, can't they, bless them, if nobody's listened to them before. What I say is, I'm picking stuff up, and then I'll say, okay, let me just ask you, is it hormones, gut and neurotransmitters, or is it hormones, gut and anxiety? And as soon as they say yes, I go, right, do me this quiz. I'm sending my questionnaires out now. Do me this quiz as well, and put your score on the front of your questionnaire. And if they've got more than a score of 10 on the KIAC test, I go, right, let's look at this and let's treat it. I will say with the scores, or even the test results, and this is another area where it's a bit grey, either your test result or your score does not reflect how much B6 or zinc that person needs, because you've got mindset and all that other stuff in there, and it's their perception of what they're going through right now that is messing up with everything else. So you just can't do it like that. So I always start low and slow. Charlotte, what is his name? Was that, oh, Navo, right, okay. Anything else? What's Paula put in there? I'll have a look at that. Could you please repeat Magnesium Guy's name? Okay, that is, the Magnesium Guy is Morley Robbins. He has a Facebook group. I don't know if he lets practitioners in now. He used to do it at one time, but he kind of keeps his patients to himself. He does this. He's not doing pyroluria particularly. He's more about this. He's more about metallothionein and copper. But his stuff's really interesting. And I think the other person who is researching his stuff now is Gillian, who does cell symbiosis. Gillian, what's her surname? She runs she's in, sorry? That's her, yeah, Gillian Crowther. Thanks, Nigel. She's looking at his stuff now as well, and she's kind of presenting it in her own way. Yeah, Sylvia's asking, do I use the Trudy Scott test? No, I use the KIAC test, if I'm honest, because it's more robust, I think. Trudy's very old now. I love Trudy's work, don't get me wrong. A book was exceptional in its time, and it's still got some really useful stuff in it, and it's great for patients. But I think we've moved on quite a bit from Trudy Scott's original book, and I think it needs probably rewriting or updating, and that hasn't happened. And it might not, because she's doing, she's still getting good results from what she's doing, so that's good. But yeah, so I use the KIAC one, and it is on one of the slides for you. Charlotte, would you mind just going over what you said about the SUOX gene? Right, okay. You might not, I mean, this only really applies if you're doing genetics work yourself, but what I'm finding with the people who come through for the genetic work, not realizing that the pyroluric, and you have to treat the pyroluria before you do any other genetic work, because it underpins most of the genes. What I'm finding is when they send me their gene reports, they might not have the SUOX gene as a SNP, so it's completely clean. But what you'll see is a sulfite sensitivity, so they'll be sensitive to things like non-organic dried fruits, trail mix type stuff, bacon, sausages, all those kind of deli meats that all have sulfites in them. Things like the Deliciously Ella cereals. Well, you think you're doing really good with those, don't you? But then they're not organic, so they've got sulfites in them, primarily because they're on the fruit. So she's not saying these are full of sulfites, but they will be because they're not organic. So anything like that, wine, that's all, a lot of that is high sulfite. So anybody who's reacting to that, and the biggest symptom I see with sulfite sensitivity, if I'm honest, is itchy skin. And usually it's after they've had sulfites, they'll start scratching their abdomen. It tends to be there more than anywhere, but it can be anywhere on the body. Some get it lumbar spine, either side of the lumbar spine, they get itching there. So it's all where the gut is, it's where the initial insult is. Name of the fatty acid test. I do my fatty acids through Body Bio direct, and they send a kit out, and the kit goes to Kennedy Krieger Laboratories. You need an account with FedEx, because that has to get to Kennedy Krieger in the States in 24 hours. So often I'll do that through Damien Downing, and his PAs will help me out with that, because they do the whole lot then from start to finish, and they just charge you a bit for the admin side. But yeah, I love that because it's got a fantastic report with it by the time Body Bio have got it. Genomic testing, and which brand? If I'm honest, I use MTHFR Genetics, who are based in Poole in Dorset. They're a Polish family. I love them. I think 5 out of the 6 of them are geneticists, but all doing slightly different jobs. They kind of did the degrees with genetics as a focus. The reason I like them is it's £175 for a complete rundown. The report is easy to interpret. They're not doing SNP treating, because the danger with a lot of the more expensive tests is it's not that they're intending to SNP treat, but they're giving enough information for people to just go away and go, I've got this SNP, I'll put this vitamin in. And those of us who've done genetics for a while know that when you do that, you actually push the person into oblivion, and it's if they've got a sensitive predisposition. So, and also if they're doing small profiles, it can cost you over £1,000 just for your genetic test. And I know you're only doing them once, but they can spend that money wisely elsewhere. So the other thing I like about MTHFR Genetics is Lucas, who runs the show. If we have enough discernible evidence to add a SNP to his profile, he will put it in. If we send him that information and then he comes back and says, well, actually, no, he usually says no, because there's another SNP that is actually bang up against the one that we've identified from our research, and because it's so close, the one that is measuring is adequate for the role. So and they can interfere with each other. The results you get can be changed by if they're too close together. So that's the only reason why I wouldn't. But yeah, that's kind of it in a nutshell. So, well, we did well there. That's brought us up to the 90 minutes. So shall we have a 15-minute coffee and pee break and come back at 1:15? How does that sound for everybody? Anybody got anything else, burning questions? No, I mean, if anybody's too shy to ask, I want it to be a safe space, but if anybody is too shy to ask, you can ask me at the end today. You can wing me some emails and it's fine. All right. Bless your heart.
I just wanted to say thank you for the beginning of it. I have been thinking and trying to figure it out, and you have answered my question about the trauma. It's so key to everything that we're doing. So thank you.
You're welcome. Thank you. All right. See you all in 15 minutes then. Enjoy. All replenished. Plenty of chocolate to keep you going. Bless you. Thanks a lot. Okay. Let me get presentation 2 up then. Slideshow. Right. And we are recording as well. So I forgot to turn the record. I forgot to stop the recorder for that 15 minutes. So you'll have to run it on when you get it. But okay, well. So this is Pyroluria 2, the bigger picture again, and this section we're going to look at the body-wide impact of pyroluria to understand the impact of it on the methylation pathways and to appreciate the pros and cons of testing as if we haven't already kind of covered that. So some of this will just, it might be repeating, and others will just be kind of tapping into what we already know and extending that. So as I kind of said in the first session, there is a body-wide impact of pyroluria by virtue of the fact that these two, B6 and zinc, are probably two of the most important nutrients that we need for life, basically. So it manifests in neurotransmitter imbalances, in hormone imbalances and gastrointestinal. And as I said to you at the end of the last set of slides, when I do my first 15 minutes, this is the area where I just say, right, okay, am I hearing gastrointestinal, hormone and neurotransmitters? Do I need to get this person to do the KIAC quiz? And then when I send the questionnaires out, I just say, please do me this quiz as well. And then we get a good kind of picture. If they're either a practitioner or there's someone who has done this nutrition work for a long time and they're doing a lot for themselves, but just with the occasional check-in with somebody, I might also say to them, you know, if you do get a score higher than 10, you might want to watch the webinar that I've done on my blog, just so that it gives them a bit of an understanding before they come for their appointment. And then you're not tied up with, because these are really anxious people, you don't want to be tied up with question after question after question and not, you know, not helping them in terms of keeping them focused. So sometimes I do that as well. We've seen this, the diagram that's just showing the body-wide impact. So the impact on methylation. Yeah.
Sorry. Are you thinking you've got your slides up at the moment?
Oh, have I not?
No.
Sorry. Oh, blast. Sorry.
It's all right.
I'll start again then. All right. So it explains why my slides are working and I'm doing nothing. Right. Okay. Sorry. Bless us. We'll start again. Sorry. Right. Have I got the right one? Yeah. Presentation. Oh dear. Right. Go away. What am I doing? It's a good job we've got a man on the job. No one else was saying anything. Oh, bless. Everybody's so polite, aren't they? Okay, Pyroluria 2 bigger picture. So yeah, I've just said we're going to consider the body-wide impacts, understand the impact on the methylation pathways, appreciate the pros and cons of testing, although we have kind of covered that in the early session. So we'll just kind of brief over. So as I said, when I do my first 15-minute chat with them, discovery call, I'm looking at what they're telling me. I'm saying to them, I don't need a full history. I just need a brief overview of what you're looking for. And while they're telling me, I'm looking for, is that neurotransmitters? Is it gastrointestinal? Is it hormones? And if it is, or if I'm suspect, but I'm not quite sure because I haven't got enough information and I don't want to be there an hour, then I'll say to them, I'm going to send you a quiz to do alongside the questionnaires. So please do the quiz and put the score on the front of your questionnaire somewhere or email it me. And if they get a score higher than 10 and they seemed as if they've done a lot of the nutrition, naturopathic stuff before, or they've been helping themselves with a little bit of check in with somebody every now and again, not even necessarily the same person, but whoever they need at that point in time, I might also say to them, I've got a webinar mainly for practitioners on my blog, and if you want to listen to it before you come for your appointment, feel free. It's free for everybody, but I just warn them that it is for practitioners and not to kind of go away and start self-treating, because obviously all this stuff that you've got here is not on that webinar. So sometimes I'll do that as well, and if they're not there, then obviously I won't, because we've got to start right at the basis for some people. The Pyrol diagram we talked about in the last session, and as I said, you can have a PDF of that. I'll send it to you all. So the important thing to look at in this session is the impact on methylation. So if we start, I mean, in previous days, before we had MTHFR genetics doing my genetic testing, I used to use 23andMe. I don't use them for obvious reasons now. But I used to use these diagrams, or this particular diagram comes from a set of 10 that is Sterling Hill's work, and I used to put all my 23andMe's through her app to get an analysis. So what I do now is I've still obviously got some of these from mine and from previous patients where I did use them. And what I do is I print off the last 10 diagrams and I annotate them for the patient. So those who are, you know, up on this stuff, trying to learn it, I just annotate it. So with regards to pyroluria, we've got all these CYP enzymes that could be affected because their action is all dependent on the reduction of reduction of heme iron. So, and that's your first port of call. So if you've got overexpression there, or you know, you're going to get a lot of intermediate metabolites here, and then in this section, particularly down here, if you've got problems here, because you've got B6 and zinc deficiency, then you're going to automatically get a pathological detoxifier. So these are the poor souls who just get toxic no matter what you do for them or with them, and then you can't get beyond that. These are the ones who, in my younger days, we would do a bit of gut work, then a bit of liver work, then a bit of neurotransmitter work, and then we just keep cycling like that, and we never really get to the bottom of it because we just had to do whatever we could do at that point in time. And as they got toxic in that area, we had to move to a different area. So yeah, we've got those. These are Ben Lynch's from his strategene thing. So thank you to Ben for allowing me to use these. What I've done here is I've annotated the particular gene SNPs that might occur as a result of zinc and B6 deficiency. Now, again, you know, you might not see these as SNPs because the actual gene might be fine. But if your patient's got pyroluria, the enzyme is maybe not going to be working. So this is a time where you've got to look at the genetics with a different light, really, I think. And certainly to support these and to understand the pathway as well, because if you don't understand the pathway and then you throw the B6 at them, then you could just make this work 10 times as hard, and then they might detox rapidly, or they might get really anxious because, of course, this pathway is all about converting your folate down to methylfolate, and then sending folate into the biopterin cycle to make dopamine, etc. So if any of this is, if this is sped up in a big way, particularly to the neurotransmitters, you could be in difficulties there. But just looking at the B6 here, we've got the cycling of 5 to 10 methylene tetrahydrofolate, which can be impaired if there's lack of B6 here. We've got this pathway that can be impaired and this pathway, and both of them are different routes to get your folate converted to methylene hydrofolate. So that just makes a sluggish system, and it might be one of the reasons why in a lot of the, I'll say a lot of them, it's not a lot, in some of the like autism spectrum, and those more severe conditions, we often see cerebral folate deficiency, and there's no telling that this might not be part of it. And I certainly had cerebral folate deficiency as part of my pyroluria. So then we've got the methionine pathway. We talked about the BHMT earlier. This is very zinc dependent. So if you've not got enough zinc, that's going to be your short route from homocysteine back to methionine might be shortcutting. And so you might end up with a higher homocysteine, which is going to be inflammatory. You might not have enough methionine to go into your methyltransferase to make all your cell membrane support, so your phosphatidylcholine, etc. Or your SAMe, you're making your SAMe up there as well. Also with this one, sometimes if that gene is expressing in a big way and you start to put phosphatidylcholine in, you can exacerbate that. And this is the one where they all internalize their stress. So if they've got BHMT and they've got anxiety, that's massively overextended. Also, we talked about CBS in transsulfuration, and we'll come back to that in a minute. So that needs B6 as well. So, and also MTR. So if you had SNPs on all of these three, you've got no way of getting rid of your homocysteine at all, because it can't shift anywhere, because those are the only three routes it's got, which explains why B6, zinc, B12 are all crucial for methylation. Yeah, so that's the thing on its own. That's the thing on its own. Really worth knowing, I think. Biopterin cycle. I love this one, because this is where I work most, I have to say. And this is absolutely crumbled by not having enough B6 and zinc, because without your B6 and zinc, you're going to be low iron, and you've got a heme processing disorder here. So there's two reasons there why all the biopterin cycle might not be working. So you might be not converting your phenylalanine to tyrosine, or your tyrosine to L-DOPA, or your tryptophan to 5-HTP, or even your arginine to citrulline, because your enos might not be working either. That's just crucial, because you can't make serotonin, you can't make dopamine. You've got someone who's just flatlined in the brain, feeling nothing, completely anhedonic. And yeah, just feeling nothing. And you'll get that from trauma as well, because there's some really good studies on looking at how dopamine falls under trauma conditions. It floors dopamine completely, which is going to take away motivation. So this person, you know, even if they're old enough to do all this stuff, old enough to work with, you've got to get the dopamine up to get motivation so that they can follow the program. And you'll see how we do that in the end thing. But yes, this I think is crucial. Get the iron up. I know there's a school of thought that believes, and I think this is quite old research now, but there's certainly some doctors I still work with who believe we shouldn't supplement iron, because if you've got a lot of dysbiosis, then the dysbiotic bacteria is going to eat the iron, and that might be the reason they're a low iron in the first place. I don't necessarily agree with that 100%, and I do find if we use a small amount of iron and maybe use something like the BioCare's Nutrisorb that goes in easier, rather than, you know, tons of like capsules and tablets, which are all going to sit in the gut, I usually find I get better results with that, and I need a lot less. Metabolics do a nice ionic iron as well. So I do find that I do supplement iron in a small amount for these people, because if it's low, they're not going to get off the deck. So yeah, just looking at that, looking at the iron from here. Iron's also the first part of the chironine pathway for the IDO enzyme. So you could end up with inflammatory stuff going on there, which is not good. And then the DDC enzyme is very B6 dependent. So that is converting 5-HTP to serotonin. So this kind of person, there might be somebody who has come in with depression, and you might give them 5-HTP and then they'll get a migraine when you think it's going to be the best thing for them. So sometimes it's working with the B6 first to get that mechanism working, and then maybe put in 5-HTP or even tryptophan, because I know the Nutrilink boys would say they don't use 5-HTP anymore. They're very much tryptophan. I do use it, if I'm honest, but I'm just careful who I give it to and how much. Again, B6 here, DDC enzyme to dopamine. So if you're not making dopamine, you've no motivation, you've nothing coming through to create noradrenaline, so the adrenals are slaughtered. And then if you've got SNPs in these pathways as well, sometimes you hope you have got slow SNPs in these pathways to hold on to the bit of dopamine you might have in this kind of person. But yeah, so that's all affected, predominantly by B6. I don't think there's any zinc in here, but if you look at this one, there's copper here as well for DBH. So then if you over supplement your zinc and you lose your copper, you might go from having no dopamine to trapping your dopamine. You know, so and I've seen this actually in a person who a really interesting case. She was a girl who had Asperger's, and she came to me. She was sent by a gastrointestinal surgeon. Was he a surgeon? Yeah, he was. She was on tube feed. She'd been tube feed through the gut. She was Asperger. She had body dysmorphia, and she was sent to me for some nutritional support. But 4 consultants were looking at her case and saying, because of this insane body dysmorphia that she had, they were going to do a sex change. So they were preparing her for that. And she was all up for it. It was all kind of, interesting stuff. And what they did was, as part of that, obviously, they've got to address the hormones. So they put her on testosterone. And then she just went off like a rocket. She came to me with suicide ideology. She did her own timeline and her own matrix, and it was all suicide ideology. And I thought, what the heck's going on here? But when we looked, she had this DBH enzyme, and she was also really low copper. And when we did a live blood cell analysis, I've never seen so many parasites in anybody's blood in all my life. It was creepy to watch it on the screen. And I thank God that her dad was a biochemist, because he was watching it all while I was doing it. And so what we saw there was, because she didn't have much dopamine to start with, and it would be and she was pyroluric as well, it would have been my thing to treat her pyroluria, because she was still fairly young, about 24, I think she was. But because they'd put the testosterone in, it had gone into this pathway. The DBH enzyme wasn't working, and so it had trapped a dopamine and caused suicide ideology. And it was fascinating to work it all out with them. And she did well in the end, and she got a sex change. But it's just little things like that when you've got these things going on due to pyroluria or nutrient deficiency. So that's the biopterin cycle. Transsulfuration cycle I've been really talking about all day, to be honest. I love this cycle. I don't think many people look at it, to be honest. In fact, I had a chat with Paul Clayton a few months ago, which was quite interesting, because Paul Clayton's a really old egg. He did one of our early books in the 1980s, but he's working with a company called Zinzino, who do this selection of essential oils based on the fact that our belief at this point in time with essential oils is that we need a lot of polyphenols to get the oils into the cell membranes and to actually stop them from degrading when they go into the body. So we can throw all these oils at people, but if they're degrading, they're just making more trouble than they're worth, really, even though they need them. So he's been working with this company. And I had a really interesting conversation about transsulfuration with him. And I said, well, actually, I love your oils and I can see the benefits and I love the evidence behind it. But I've got a major issue with this, and that is a lot of my autism spectrum, they can't sulfate, so they can't break down the polyphenols to start with. So what are we going to do, if we want to use your oils? And he basically said to me, that doesn't exist. Transsulfuration issues that don't exist. So that was kind of, all right, go back to the drawing board and have a look. But Stephanie Seneff's done some amazing work on this. And I don't think there's anybody that rivals her. And she's been at it since she was 10 years old, probably. And she's probably in the 70s now. But she talks loads about this particular system. And of course, here we've got B6 at the CBS enzyme. We've got zinc at the CTH enzyme. We've got B6 here at CDO1. We've got B6 at this one, CSAD, converting the sulfurs to the taurine. We've got B6 here, which is going down this SUOX pathway, creating sulfite and then sulfate. And of course, it's the sulfate we've got to attach to everything. And then if we go into the superoxide dismutase pathway, we look at all of this here. When we make hydrogen peroxide, which is that split second reaction that helps to kill all the bugs in the system, if we can't make superoxide because we haven't got superoxide dismutase, then we can't quell that huge reaction. So what we're doing literally is throwing a hand grenade at the problem. And we all know what happens when you throw a hand grenade in the room. So this is one of those massive areas where we get a lot of free radical damage. And this is very kind of copper, manganese, iron area. So again, it's very, there's quite a lot of nutrients to consider here. But I think the danger of this pathway is throwing B6 and zinc in too quickly, particularly in a more mature person. It really doesn't happen with the kids at all, unless they're really severe autism spectrum. And then you're wondering why their behaviour's gone off, but of course they can't tell you. But certainly in the more kind of mature, what generally happens if you throw B6 and zinc at them, you open up the CBS enzyme, you flood all the toxins into this area, and then they just feel lousy. And it's because the rest of this pathway isn't opened up, and it can be anywhere. This GSS enzyme particularly needs glycine. So when I'm looking at these people, I'm always saying to myself, yeah, well, they've got fibromyalgia, so, you know, magnesium malate might be a good thing for that, but then they've got pyroluria, so I tend to go for magnesium glycine more than anything, because then we're opening up all of this pathway for them. They need the B2, and sometimes they need selenium as well, because they need to recycle the glutathione, because if that's oxidizing because of all the free radicals, then they're going to get they get migraines and headaches and feeling crappy when they start to take glutathione as well. So you have to look at that as well. Histamine. Don't know what you guys are seeing at all, but I'm seeing more histamine now than I've ever seen, and I don't know if it's because we're just becoming aware of it. Because a lot of people have been talking about mold for the last few years as well, and mold obviously blocks all the histamine SNPs. So that's another thing to look at actually while we're talking about histamine. We've got the HDC enzyme, which converts histidine to histamine. So we're creating histamine, and histidine you can measure on your organic acids. So if that's high, you question whether this enzyme's working. So that's a good way to look at it. The ADH enzyme, which is breaking down your alcohol, aldehydes. Again, you need zinc for that one. And same at the other side, breaking down your DAO once you've used your DAO enzyme. So they're kind of key areas. But as I said, think about mold with this. And again, I learned this through personal experience. If you've got any SNPs in this pathway whatsoever, and you have a mold insult that's bad enough, mold just gets into the central nervous system so quickly, it's terrible. But what it does is it blocks all these enzymes. So you can't break down histamine, so you're making it, and then you can't get rid of it, which is going to cause cell danger response in a big way. And then you get mast cell activation. That's what happened to me when I had the near death. It was mold-induced pneumonia that then blocked all my histamine SNPs, and then I went into mast cell activation. And it's quite a scary place to be honest, both for the patient and the practitioner. And then you need to flood the body with phosphatidylcholine, because it's just the histamine just breaks it down quicker than you can make it. So what does all this mean? Well, I guess to start with, the premise is that methylation is homeostatic. So it's going to waver according to whatever's going on in the body. If you've got cancer cells being produced, then it would make sense that the body would have a mechanism for trying to stop that escalating out of all proportion. And I think one of the ways it does that is by downscaling your methylation. The body doesn't want to make more sick cells. We're not here to come here and have a miserable existence and then die, are we? We're here to do good work for humanity. That's the whole point of it. So it makes sense to me that methylation would be part of that mechanism at least. It is a process of building up and breaking down hormones, neurotransmitters and cell membranes, and loads of other things besides, but you know, that's kind of key. It's also a process of detoxification, so it gets rid of endogenous metabolic wastes and toxins, so anything that the body's making through its own building and breaking down. It also gets rid of exogenous metabolic waste, exogenous waste, so that would include things like glyphosate, heavy metals, chemicals of all descriptions. And then it's a process of support. So it sulfates vitamin D for us. If vitamin D is not sulfated, then it often can lead to a rise in the blood and we go, all right, well, your vitamin D levels are normal, so you should be fine. But it might not actually be doing anything, because I think we've got something like 32 SNPs in that vitamin D pathway. It only takes 2 or 3 of them to be down and it's not going anywhere anyway. What we do in the emotional detox program with Nikki is we generally don't recommend vitamin D supplements anymore. We recommend the Spurty lamp, which is designed, it's just a small sun lamp and it's designed for vitamin D to be created under the skin as it should be. And because we're in a dark country for 6 months of the year, we're not going to do that anyway over winter. The other place it supports is the ion gate channels, of course, because you're going to create cell membranes from your phosphatidylcholine and your omegas. And those ion gate channels allow minerals, electrolytes to go backwards and forwards. If you haven't got electrolytes, nothing's going to work anyway. Or if your electrolytes are unbalanced, nothing's going to work. So thinking about that, there is a huge need, particularly with, I would say, anybody over, let's say 20, just as an arbitrary figure. It's not cast in stone because we have to massively detoxify the severe autistic kids in a big way before we can do anything with them. But so if I just use 20 as a kind of a broad brushstroke idea, all channels of elimination need to be open. There's a guy called Damien who uses some really nice homeopathic products to do this. What's his company called? I think it's called Precision Health. He does some really good education as well, and it allows nutrition therapists to use homeopathy because the complexes are very specific for opening up channels of elimination, but in a kind way, rather than throwing a lot of supplements at a liver that's already not coping with what it's got to cope with. But I'll find his link and I'll let you have the link to him. He's interesting. So when you were thinking about all this and the need to detoxify, very often methylation or pyroluria might be the last correction in the sequence. Because as I said earlier, if you've got trauma and you're trying to fix this, or if you've got a severe case of pyroluria and the person's off their heads, bless them, you start throwing B6 and zinc at them, they're going to release heavy metals, they're going to release chemical toxicity because the methylation is going to start to fire up again. And if they can't detoxify, the body's going to be stuck with all of that. And then it's all going to come out through the skin. And if they haven't got psoriasis and eczema and God knows what else before that, they will have by the time we've done our job. So it is a case of, it's a bit like, what's the scenario? It's like the onion. It's like we're an onion and we have to peel everything off in backwards order so that we don't mess up the system and we don't kind of, we don't pull the bean tin from the bottom of the pile and let all the others go flying. We often need to do total body support for detoxification. And that might be more than nutritional support. It might be things like, well, it's going to be things like Epsom salts baths, ion cleanse, which I've got a link to for you as well. Far infrared sauna, those kind of things. And above all, we absolutely must support transsulfuration. So this is from Clean Hearts, and it's the Townsend letter, and it was only this year as well. And what Clean Heart's saying is, in people with cancer and active Epstein-Barr infection, the Epstein-Barr triggers a hypermethylation inside the cancer cells that may accelerate cancer growth. If methylation support is introduced based on genetic SNPs or other lab testing, but the patient has an untreated active Epstein-Barr infection, such as chronic fatigue, Lyme disease, or any other related conditions, or an Epstein-Barr virus-related cancer, such as throat, stomach, breast, or prostate, or Hodgkin's lymphoma, then supporting methylation might lead the patient to an increased risk of cancer or an accelerated rate of the cancer growth that they already have. And this is the one thing that sometimes puts shivers up my spine when I see SNP treating on BANT, because we've just got to be really careful. You know, we have to look back and say, why is this system down? Not just kind of throw vitamins at it. So I think that is just a crucial thing to take away, that, yeah, we've got this thing to help people with, but we've really got to be mindful of how we do it. So if I move on to testing, there's a number of reputable laboratories. The pyroluriatesting.com or DHA laboratory is the one that William Walsh says is the best in the world, the absolute best in the world. He recommends this lab above all others, but for us, if we've got to get our our sample to that lab within 24 hours, that is going to cost an arm and a leg in courier charges. So you either have to have an account with FedEx, who will get it there in 24 hours, or anybody else who you trust to do that. I mean, I know that FedEx will pick up from me at 2 p.m. in the afternoon, and I know it's in the lab at 8 o'clock next morning. But as I said, I do that through Damien Downing, rather than pay the X number of pounds a year that you have to pay to FedEx to have that service. So I think, to all intents and purposes, unless we're in the States, that lab might just be off, you know, just be off our radar, to be honest. The next best one that he says is the HPU test in Europe, which is John Camsteed's work. And actually, John Camsteed's got a nice little booklet that he charges about, I think it's $15 or whatever their currency is, 15 something euros, is it? And you can download it, it's a PDF, and it's quite a nice little book, you know, for people who are just learning about this. I like John Camsteed, he's got some good stuff to say. John and Mark from Biolab used to do this testing together. And this is a little trade secret. When I spoke to, as I said to you earlier, about talking to Mark about this and doing those 20 tests, I asked Mark about this, and he told me quite categorically, Biolab used to do all John Camsteed's testing, but then John got it in his head that HPU was better and moved on. So, you know, that's another reason I kind of stick with Biolab until somebody tells me anything different. In Australia, if you've got patients out there, the safe analytical laboratories are the ones that they seem to like best, or the applied analytical laboratories. It's not difficult to get a test in Australia at all, because this is common news to them. And if you wanted more information from that Townsend letter, there's the link there, so you can go and read it for yourself and hear what Clean Heart's got to say. So in terms of testing in the UK, as I said before, Biolab measures KPU rather than HPU. We did this small pilot of 20 samples in 2017. We used the Kiak Parkstad, which is the Dutch provider. And what what the KIAC lab provided us with was the 24-hour urine collection pot and then a 10 ml urine bottle. So we just had all 20 patients collect their urine for 24 hours and then just decant into 2 urine bottles, which then went to the respective labs. And as I said to you earlier, the 20 sample results were all comparable, apart from one that was slightly off. And we never quite worked out what went wrong there. It might just be that the urine wasn't shaken up and there was a lot in that tiny bit that went into the measuring cylinder. So the background to testing. In the 1950s, I think I said this at the beginning, all mental health admissions were tested and treated as appropriate for pyroluria. Then we got all these tricyclics, MAOIs, SSRIs, SNRIs, and testing kind of stopped because I guess when you've got a medication, there isn't always the need for a test. We deny that now because we're going more into testing now than we ever have before. So, maybe it's a shift of mindset, but also, as I said before, we've got this big issue with stability of the Morph factor, or the KPU, HPU. It dissipates with heat, light and oxygen. It can only remain stable for a maximum of about 8 hours, according to William Walsh, which is why he likes the labs in the USA. And of course, he's there. So anything over 8 hours, you've got to kind of look at your result and say, well, how does that compare with the quiz and their overall timeline history? And I mean, as responsible practitioners, we do that anyway, but this is just kind of reiterating the point. There's also a big inconsistency in instructions from the laboratory for collection. I find that some laboratories, they don't really say to you, do it when the patient is stressed, or stop your B6 and zinc, because obviously if that person's been on B6 and zinc for a long time because they've worked out that they needed them for some other, by some other divine intervention, then stopping them for a couple of weeks to do a test will just make them really incredibly anxious. So that information's left off as well. And so obviously, by the time it goes to the lab, there's so many variables that might interfere with the result that we do get false negatives. There's no doubt about it. I have also had it the opposite way, where I had a nurse who had years and years of depression, anxiety, couldn't get her act together, had actually stopped nursing on the wards and was doing a mental health, more admin type role where she helped people to be aligned with certain people who needed care in a mental health kind of setup. And even that was stressful. And because we were in COVID when I first saw her, she was doing it all from the phone. And that was pushing her anxiety up because she couldn't actually physically or visually assess that person with the mental health disorder. And so she was relying on the relatives or the carers to give her information, and obviously that information is not coming from a clinical eye. And so she was, you could see that she would be off the scale, but she was also taking SSRIs. And I actually said to her, but being a nurse, she would obviously want the test. I can say all I want about, well, you know what, I'm not sure that you need the test because your numbers are high, etc. But she's a nurse, she's going to want the test. Most nurses would. And so she did the test, and I said to her, your SSRIs might have brought your stress down so much that you'll get a false negative. So let's talk about how we're going to deal with that if it happens. And I fully expected a false negative. And when it came, a score was through the roof. So there's one for me, a kick in the eye to say, actually, think about what you're saying. So yeah, you can get it both ways. We've talked about the and the stability of the Pyroluria Nov factor, whatever we're going to call it, is dependent on a lot of things. If this is trauma induced, then the chances are we're going to be able to, if that person is able to and keen enough to explore the trauma and get the appropriate work for that, then you can treat the pyroluria and you can get it out of the system and you can get them off the supplements. And I can honestly say the place I've seen this most has been inside Nikki Gratrix's, what used to be the emotional detox program, but it's now called an ascension program. And I'm seeing spontaneous remission of stuff like this inside there, like I've never seen before. So you can get them to a good place. I think the trauma work, who knows how long that takes, and that's not our role. What our role is to send them to an appropriate person. And I do that based on Klinghart's 5 levels of healing. And I have a certain few that I'll tell you about as we move on, who those people are and why I think they're most appropriate. And they cover most things as well. So yeah, so trauma, yeah, we might be able to just completely eradicate pyroluria. If it's genetic, again, there are some people who have had remission of this where we've thought it was genetic. Obviously, we can't go through every family member's genes to see if it is genetic. We can only look at traits and whether they're in different people in the family. But also within those families, we've also got to consider, is this actually a genetic trait or is it a societal thing? Because they've all got similar, they'll all have a different view of the world, despite the fact that, you know, you might have 6 kids and they've all been brought up by the same parents. We all have a different view of our parents. And when we get older, we start to talk about these views more. So you start to get a handle on how someone else of your siblings saw your upbringing. But so, you know, there's all kinds of things in the genetic mix. There's also the fact that they would have eaten a similar diet. So how has that affected the microbiome? So with the genetics, unless we have a gene that says this causes pyroluria, that, you know, that is not kind of a SNP type gene, it's one of the ones that we know cause a scheduled disease, then can we say it's truly genetic? Who knows? It certainly can be infection induced, and certainly Klinghart has shown us that with viruses. My pyroluria went absolutely through the roof when I had the mold-induced pneumonia. And I ended up treating it exactly as Klinghart, well, not exactly as Klinghart does it, but, you know, I needed high doses of stuff to get me down again. And of course, initiating a pyroluria protocol will liberate heavy metals. And then we've got to be really, really careful that we don't allow those heavy metals to go through a leaky blood-brain barrier and cause mental health problems. We've got to be sure that we're binding them all up if they're in the gut or in the systemic circulation, and how we do that with safety as well. So there's all sorts of things to consider here. I haven't really talked about porphyrin. Some people do a porphyrin test because they believe it's a better test of heavy metals. I mean, most of us would kind of do urine and blood heavy metals and accept the levels, but certainly the older generation, they all did the porphyrin test instead, because in the hunt, and the link between pyroluria and porphyrin is, if you've got a porphyrin disease, there's no doubt about it, you will have cryptopyrroles, hemocryptopyrroles in the urine. If you want to do porphyrin testing, the Laboratoire Philippe Auguste lab in France is the best for testing this. Doctors Data and Great Plains, I'm not sure if they still do it actually, they both did at one time. And how they use this is, if they find high levels of uroporphyrin, that indicates there's a high aluminium load. So that can be really good for the dementia patients, because we know they have loads of aluminium. Or people who've done dialysis, they end up with lots of aluminium as well. The corporaphin, that indicates lead toxicity. I haven't seen lead for a long time, but I've suddenly seen a surge of it recently. I don't know where that's coming from. And then we've got precoporaphin, which indicates mercury. So yeah, you can use that test as well if you want, if you've got access to it. Now this is interesting, and I think this was Klinghart's as well. What Klinghart says is, when zinc is missing from the body, it is replaced in our bones with lead. And if zinc is supplemented, lead is expelled. Or maybe that's why I'm seeing more of it then. And secondly, the enzymes needed to detoxify these metals are heme-dependent enzymes. So when the metals have accumulated, heme synthesis is abnormal. So is this, I mean, so it begs the question, could this actually be a heavy metal insult? Could this be just someone who is mineral depleted, because our soils are mineral depleted? We know that. And is this coming actually from there, from heavy metals? So what about hemocryptopyrroles and histamine, or cryptopyrroles and histamine? We all know, those of us who deal with histamine on a regular basis, when someone's having a good day, the histamine levels are okay. You know, and when I say a good day, I mean emotionally a good day as well. When they're having a bad day, the histamine is through the roof. So it's not really the relative blood level that is the big concern. And of course, that's a homeostatic mechanism as well. The histamine fires up, but then it comes down within 2 hours again, but it's the damage that it causes. It's the whole hand grenade effect. The damage that it causes to the blood cells, red blood cells predominantly, that is the issue. So this person's going to have more reactions to foods, inhalants, chemicals, allergens, emotional stressors, electrosmog. And even with that kind of person, a low to moderate histamine shift is going to experience a lot more symptoms. So with histamine, whatever level you've got in the blood is not reflective of the symptoms at all. Minor biochemical changes can cause catastrophic symptoms. These are the people who are just, you can't do anything with them because the histamine's just all over the place. And yet, and again, I put my hand up here and say I was one of these. When we did all my testing, I knew exactly what had happened, because I didn't know I had pneumonia at the time, and no one told me I had pneumonia. I just thought I had a chest infection. But I knew that I picked it up in America, in Seattle. And then on the plane home, I'd ordered a gluten-free meal. I won't fly American Airlines ever again as a result of this. I'd ordered a gluten-free meal and there clearly wasn't one. So they put me a plated meal together. So it didn't come in a plastic wrap like everybody else did. Mine came on a plate. And I thought, my instinct said, don't eat that, but I was starving. And it was only salad. So I thought, well, can't harm a flight or a flea, really. But it obviously had high fructose corn syrup on it, because I tasted the sweetness the first mouthful and then I had anaphylaxis. So I knew all that had happened. And then when they did my blood levels of histamine, the histamine was fine. Because, I mean, to be fair, I wasn't tested until I come back to the UK. Luckily, they did get me home, didn't have to pull the plane down. But I went straight to A&E when I came home, and they did all the checks and there was nothing on the checks. And I was discharged and then collapsed a week later. So, you know, it's interesting, all this stuff. We generally don't really find what we're looking for with histamine at all. So Klinghart's worked with biochemists in Germany, I have to say, the Germans, aren't they clever? You know, the German physicists just have got it, haven't they? They're beginning to link cryptopyrroles with mastocytosis or mast cell activation syndrome. They've observed quite strongly that KPU treatment repairs the heme molecule, which then stabilizes the mast cells and lowers the response to those that have relative rises in histamine. I think it's fascinating how all this just comes back to one thing. They've identified some lab indicators that we might want to look at. So white blood cell counts less than 5,000, sorry. And these won't be our measures, they'll be American measures, aren't they? They can be due to low levels of zinc, the high LDL, low LDL we saw in the last set of slides, low normal alkaline phosphatase, low omega-6 fatty acids in red cell membrane tests, low taurine in amino acid profiles, high MCV, low glutathione and low ATP, and they're all kind of indicators for this. And sometimes there are better ways to go, really, because if you're a person who uses like the functional DX, you know, or you're a GP and you're doing more blood tests than anything else, you know, a lot of us haven't had that in-depth knowledge of interpreting these. I know we've got Dick and Weatherby's book, but it takes hours to go through and put all this together, doesn't it? So if you're doing the functional DX test, your quid's in. But you know, those kind of people, they'll whiz through this and they won't need to do a pyroluria test because they'll do it on the bloods. I do it through the organic acids because I can see it on organic acid. So you know, there isn't always a need to test directly. So in the laboratory indicators, what you might see is white blood cell and red blood cell zinc and manganese levels might be normal, but then biopsies from bone and central nervous system will be completely deficient. We're not going to get biopsies from bone and central nervous system. It's just not going to happen unless, why would they do it? Unless there's some real indicator of maybe bone cancer or something. It's just not going to be. And even then, they probably wouldn't electively test for zinc and manganese. I don't know. But these people are saying bone biopsies are a reliable predictor of KPU and of the severe deficiencies of zinc, manganese, lithium, calcium, magnesium and molybdenum. They often find those, so interesting in itself. Also interesting is alkaline phosphatase is magnesium and zinc dependent. We've been talking about them all day. Low alkaline phosphatase with adequate magnesium intake might possibly lead you to KPU. Alkaline phosphatase of less than 55, a zinc deficiency is suspected, and less than 40, zinc deficiency is likely. So, you know, you've got some really good markers here. Whichever way you do it, you're not actually dependent on a pyroluria test, depends what you use in your practice. Some consequences of pyroluria. Low glutathione is one big one. And I often wonder if this is why Ben Lynch puts glutathione in right at the early stage, because he's a big glutathione man. Obviously low ATP. And if you look at the chronic disease or chronic illness profile, these two are really common. And Klinghardt would say these two, looking at these two alone should trigger the suspicion of KPU. And again, you can see this on your organic acid test if you're an organic acid person. So we've got through that a little bit quicker. So let me go to the questions and see what questions we've got. 18 new messages, let me find them. All right, okay. Now we've got to go back. Where are we? All right, okay. So a support group for HPU that I know of. There's a few, but they tend to be very Facebook driven. So they're full of patients, and obviously as a practitioner, you're going in there, and whilst you might pick up some really useful stuff, and there is some real gems in there sometimes, it is all patient-led or people who are trying to fix themselves. So some of the information you might pick up might not be exactly what you need, and might not even be right. But there is loads of them. I think maybe the Australian ones are going to be better because they've been doing this for much longer, but we've definitely got a couple of Facebook groups. And as who's done that, Charlotte, yeah, 9.7k members, there's loads in there, isn't there? BHMT choline link. The BHMT enzyme, if it's expressing, causes the person to internalize all their stress. And when we give choline to support that enzyme, the choline exacerbates the problem. Now, I haven't exactly found the link to why this happens, but what Patricia Kane says is, obviously choline's got to be methylated. And if you give someone straight choline, like you might get choline in a B vitamin, she steadfastly supports the idea that that feeds the bad guys in the microbiome. I can't see any evidence of that, but you know, Patricia Kane's one of the most well-researched people I know. So I trust what she's saying, and I don't do it if, you know, but then, you know, you've got to question why that is. But I do see that people do react quite strongly if I give them phosphatidylcholine, and that BHMT enzyme is lacking in B6, or it's got heavy metals or something attached to it. So, and these are the people who you might give them phosphatidylcholine because they might have mast cell activation going on, or, you know, they've got cell danger response, but then they react negatively to it because I think there's only two reasons you can react negatively to phosphatidylcholine. This gene is one of them. And the other one is if they're so incredibly toxic that when you give them phosphatidylcholine, the body just goes into detox mode, because it's clean. Phosphatidylcholine's cleaning the cell membranes, as it were, replenishing them. So all those toxins are going to come off the membranes, but then they've got to all go through the liver and then out through the gallbladder and the stool. And if that mechanism's not working, then obviously people are going to feel more and more toxic, and that's going to exacerbate their anxiety as well, if that's their key symptom. Marta, with regards to the ferritin, I think with the Morley Robbins does a really interesting test where he's looking at iron, ferritin, TIBC, red cell magnesium, zinc, manganese, B6, and a few other things. And he's putting that all in a package because it's all about the balance in that system. And it's probably worthwhile following him to really understand that system. I'm not sure I completely get it. There might be somebody in the audience who actually does. I'm not sure I completely get it. Charlotte, iron patches. I don't know anybody who does iron patches other than Patch MD, and I know that somebody had a really bad reaction to those a couple of months ago because they come to me for some peer support. Yeah, I don't see why I don't see why you couldn't use an a patch. I mean, I tend to use patches for a lot of reasons. If people have got a raging dysbiosis, it's sometimes the easiest way to get stuff in. And I love them. And I often do DMSA with a general liquid multivitamin to get it across the skin that way. So yeah, I don't see that that's a problem. I mean, if the iron's going to feed the bugs, it's going to feed them wherever they are, you know, so there is that aspect to it. But often with the patches, they take 8 hours to migrate into the body, so you've got a longer time span to play with that. Supplementing zinc and copper together, again, depends on the type of copper. I often use, depends on the patient, but I often use glutathione HPU, particularly for the kind of 30, 40, 50-year-olds. The reason I use that is because it is synergistic. It hasn't got everything Klinghardt says it needs. I do find the core, BioPure core, which is Klinghardt's own, I do find that works better for the kids, and you can titrate it because it's lower doses, whereas the glutathione HPU is higher doses. I think it's 50 milligrams of B6, but it does have a tiny bit of zinc in it, because you've got to be really careful if you're supplementing these high levels of zinc. I mean, personally, I try not to, but if you are supplementing those high levels of zinc, you are going to deplete the copper. And I think that's the thing you've got to be careful of when you're in the Pyroluria groups as well, because they talk endlessly about copper dumping, but it's not just copper dumping, it's heavy metals completely. But yeah, I think, and there's a guy that Molly Robbins used to work with, and I can't remember his surname, is called Charlie something or other. He created a company called Synergy, and the products are of that name, and he says we need copper 2 rather than copper 1, which is normally in supplements. And so he created this copper synergy, which I did use for a while. Now I don't think Molly Robbins is still using that now. We'll have to tap into Gillian and see what Gillian says, because she's the one who's following Molly now. I've gone off him a bit, but we'll see what he's saying now. But yeah, I think some people would say, yes, you must supplement copper, but only at a tiny amount. Whereas normally the ratio is 10:1, isn't it? And I think once you've corrected the pyroluria, then you probably do need to supplement at 10:1, which I think is why that glutathione HPU supplement is so popular, because you're just putting them on the one supplement and you're leaving them on it, especially if you think this is for life. So connection between HPU and histamine sensitivity and tinnitus developed after the menopause. Why would that happen? Well, I would say tinnitus is, in Chinese medicine, tinnitus is all kidney related, isn't it? I would question tinnitus can have so many underpinning issues, and it might not necessarily even be related to the pyroluria, but the things that I've seen related to tinnitus have been high oxalates because of a high yeast overgrowth. If you've got a high histamine, you're likely to have a massive dysbiosis, so that would affect blood flow, and that would affect, I would think that would affect tinnitus indirectly. But I think oxalates are the biggest issue. What is the name of the oil person? Oh, that was Dr. Clayton. Is it David Clayton? He wrote a naturopathic book or a nutrition book a long time ago, and the oils that he is using, they're called Zinzino, so that's ZINZINO. Sylvia, I guess you've had this issue then, people reacting to manganese even at very low doses. I have, absolutely I have. Sometimes when I start people off on this, on the pyroluria program, if we don't have the genetics, well, even if we do have the genetics, sometimes we look at the genetics and go, do we need to do that a bit first? And I mean, I always start with sulfation. So manganese might be one of the first things I put in. Molybdenum might be one of the first things I put in as well, to start helping the sulfation pathway to work. And I have seen someone really react really badly to manganese. And all we did there was we stopped the manganese and we went in with the glutathione HPU first. And I think sometimes you kind of look at a case and I won't say you're not sure, because you're fairly sure when you set a case up, but you look at the detoxification pathway and you say, right, I need them to be detoxifying. And of course, manganese is the sodase enzyme as well, which is crucial. And it would make sense to put that in, but then if it's not the right time in the detox program, then they'll fall over even though you think they shouldn't, because you're putting some strain on another pathway that's also struggling. So in those cases, I've had it both with manganese and I've had it with molybdenum. And in both cases, what I've done is I've gone straight to the glutathione HPU supplement, or I've looked at them and said, why is this person reacting when we are only opening up the end of the methylation pathway or the sulfation pathway? And it's usually been something like a massive dysbiosis or a massive yeast overgrowth. I think when we come to section 3, you'll see how that all fits together. But sometimes you've just got to play around, because what you think will work doesn't. And then you've got to go, right, okay, so that might be that bit of the pathway. And sometimes you've just got to support synergistically and just do the whole thing at once, so you're supporting the whole pathway. And for me, that's where the core supplement comes in, because the core is fully synergistic and it's low doses. So you start on one, you leave them on it for a couple of weeks, and then you add another one in. And I often ART or energetically test for a dose, so I can give them a ballpark figure of where I expect them to land in terms of the dose. Vitamin D lamp, that was Sperti, SPERTI. They're in America, but these days, to get something quick and cheap from America, because we're having loads of issues getting them across customs at the minute because of Brexit, etc. What I would suggest is open up an account with what are they called? It's just come off the top of my head. Shippy2, all in one word, Shippy2. It's a free account, and what you do is they give you an address and you ship your product to that address in America. And then they notify you when it comes in, and they tell you the charges to transport it straight to you. And then they send it out to you. So it doesn't come direct from the company. And some companies won't send to the UK. So if they do send to the UK, it's worth looking at their charges to transport it and looking at Shippy2's charges, because you can get it dirt cheap. This applies to supplements that we can't get in the UK as well. You can do it all through Shippy2. And it only costs you whatever it costs you for your to your courier charges. So that's a great thing. I do all sorts through Shippy2. Oh, Sylvia, thank you for sharing that. A new place called Vistas, who do well for detox homeopathics. I mean, I'm not a homeopath, so I tend to send people to the homeopath. Or if I think I'm odds on to manage it with something that Damien's got from Precision Health, I'll do it that way. But the naturopaths are better at this than us. CNM students get all that kind of help, but we don't. Ruth is asking about the organic acids as a method of recognising pyroluria. There isn't any research on it. It's just a matter of learning the patterns that occur in the organic acid test, and then being able to predict what's going on from the pattern. So obviously they've got B6 that they measure directly, active B6, active B12 folate, and then they'll do a zinc measure based on what's coming up on the organic acids. And then there's certain patterns you'll see, like you'll see low neurotransmitters, you'll see high dysbiosis markers, you might see a high Clostridia marker, because that's going to interfere with dopamine, and it's getting used to those patterns and being able to just look at that and go, oh, that looks like a pyroluria case. But that's kind of I guess that's an hour's talk in itself, really. Recommend plasma zinc or copper and ceraplasmin. Yeah, I mean, Charlotte, yes, asking to request suggestions to request plasma zinc and copper. Some people do that, absolutely they do. Morley Robbins has his own test that has all of that on. And so, yeah, absolutely, if you need that level, well, it's not if you need that level, it's when you want the confidence to be able to know exactly what to do at that point in time. And as I said, sometimes it's the patient that wants this as well. So yeah, you can. And most labs do it. You know, most of the labs that do blood testing will do all this. What about Sue? Non-existent mucin layer contributes to histamine sensitivity. Yeah, absolutely. I mean, the low mucin layer generally comes from low phosphatidylcholine, so not being able to methylate that, and low stomach acid, and then never-ending stress. And when you're in never-ending stress and your stomach acid levels are persistently low as a result, what the body does, once it goes into a, let's say, a chronic fatigue situation, loosely, what happens is the body is then trying to conserve energy, because we're supposed to live 70 years and 10 or whatever that figure is now. Doesn't matter if we're on our backs, but you know, we have to live that length of time with flowers at the end of the day. So the body's going to do everything it can, because the body has its own innate wisdom, to try and keep us upright and, you know, keep us going. So what it does to conserve energy, if you haven't got mucin layer, if you haven't got stomach acid, then you don't need the protection on your internal walls of your stomach to protect you from the acid. So it's going to downregulate your mucin layer. So absolutely you'd see histamine sensitivity, because anything that is histamine promoting, because bearing in mind, histamine is one of the compounds that stimulates stomach acid. And so, you know, when you've got somebody with gastroparesis or somebody who's dying with a non-functioning gut, and this is how my dad died, it was fascinating. Well, it wasn't fascinating in one sense, but it was fascinating to watch from a biochemical perspective. He went into hospital in his final few weeks with transverse colon blockage. But actually, when he was too sick to have a colostomy, or even, you know, to go through any kind of surgery. So we elected for a palliative care package for him. But what was really interesting was he was supposed to come out in about 48 hours, and he didn't come out for 8 weeks because they couldn't stabilise his potassium, because his cell membranes were dogged, really, and he was at end of life. And because his potassium couldn't remain in his cells because of his cell membranes, his gut wouldn't work, and that's why he'd got the transverse colon blockage. There was no cancer, there was no inflammation, nothing. This was just pure body giving up the ghost and having it. And what happened was I negotiated for him to come home, because obviously I wanted to nurse him in his last few days. And we got him home, and the first thing that happened was he had a massive histamine reaction, and he was head to foot in this itchy urticaria that I've never seen before in my life. I thought it was a big outbreak of psoriasis, because all my siblings and myself all have psoriasis, so automatically we look at that. He's had it occasionally, but a tiny amount on one elbow or something, you know. And so we just looked at that, and then when I realised it wasn't psoriasis, I just went, oh, this is histamine. So you're going to get that. And I mean, he's a guy who had the standard treatment for ulcers, came out of Malaya, had got a stomach ulcer, had the standard vagotomy and pyloroplasty, so then went into panic attacks, hid them all because he's a nice, gentle man and they don't have panic attacks, and then went into atrial fibrillation. And I just looked at his timeline and went, yeah, look at that, you know. But that was really interesting at the end. So yeah, histamine sensitivity, absolutely. What I do for mucin layer, and when I wrote the book with Damien Downing, the what a lousy title, but the vitamin cure for digestive disease. It was very American. I did some of the research on ulcerative colitis for that book. And what I was uncovering with that was ulcerative colitis, we all know, occurs at the anus and then works its way up, tracks up. And what the research is showing us, it's because phosphatidylcholine, we make it obviously in methylation, we secrete it in the first part of the small intestine, but when we've got irritation, inflammation, whatever going on, cell danger response, by the time it gets to the large intestine, there's no phosphatidylcholine left, it's all been used up. So that's where we get all the ulceration. And I found that fascinating. So one of the key things they use is phosphatidylcholine if they can afford it. But Body Bios is like phenomenally expensive. And I know when I had my mast cell activation, I had to have 40 mils of that twice a day. So it was hundreds of pounds every couple of weeks, but it was worth every penny, you know, to get well. So phosphatidylcholine is a biggie for me, and it's as much as you can get in really, or as much as they can afford. So you can start with as little as 5 mils, and it's going to take longer, but at least you're going to work on it. Mucin foods, things like linseed, if they can tolerate ground linseed, chia pudding. My son had a torn esophagus. This is funny. It's not funny, but it is. He was rushing out, and we were taking B12 at the time, and we were taking the Pro Health B12, which comes in its own little packages, push, you know, there's little push packs. And I'd put them all in his pill pot. And we'd done this for 4.5 years, and he was rushing out of the door, and he just went, and the thing tore his esophagus. So he's on the floor, and he's a bit of a drama queen as well. So I wasn't really sure whether it was right or not, but he's on the floor, he's coughing and trying to cough and splutter, and everything's hurting, and he's in all this pain. We took him to A&E, and yeah, lo and behold, it swallowed this packet, and it had torn his esophagus. And they gave him some Gaviscon, obviously. They gave him some painkillers. We were there at least 12 hours, if not longer. They let us out at midnight, having decided they weren't going to make him have a gastro test or anything. They weren't going to keep him till morning, and just sent us home with the Gaviscon, etc. And next morning, he'd paced the floor all night in pain. The Gaviscon made it worse. And then in the morning, I thought, oh, do you know what? I'm just going to give him some chia pudding and see what happens. He hadn't eaten up to that point. And I just, rather than invade his privacy, I just said, tell you what, son, when you feel up to eating, there's some chia pudding in the fridge. It's nice and cool. It'll cool your esophagus. It might make you feel better. And I went off for the day. Cruel mum that I am, went off for the day because I had a training program booked. Messaged him a few times, didn't hear anything back, and just thought it'll be fine. He'll be sleeping it off because he was sleeping when I left. And when I came in at 4 o'clock, he was cooking dinner. And I said, well, that was a turnaround from this morning, wasn't it? And it was the chia pudding. I said, what helped? And he went, chia pudding. So that one, I love it for that reason. Zinc carnosine is also a really good one. We use zinc carnosine loads for GI problems such as gastric ulcers, etc. So anything that works for an ulcer. Licorice, deglycerized licorice, if you can get them to tolerate that. It's full of nickel. Nickel is deglycerized licorice, so if they're nickel intolerant, they won't tolerate it, but otherwise, absolutely. Marta, Zinzino, okay to use for pyroluria? Well, Paul Clayton would say so. I think omega-6 is more important, but I have used Zinzino secondary once we've got the omega-6 up. Glutathione HPU, no, that's not a Klinghardt supplement. It's one of the herb companies in Natural Dispensary. If you go to Natural Dispensary and just type in glutathione HPU, it'll come up in your search engine, Rika. Yeah, it is Epigena, and I said it's Epigena, yeah. Spell shippy too, right? Okay. SHIPITO. So shippy. It should be ship it to, but it's all one word. Thanks, Sylvia, for that on the new vistas. All right, and for the shippy2.com. So thank you, everybody. That's been really useful for everybody chipping in and sharing all their ideas. We're at 1:45. Do you want an hour or do you want 45 minutes?
Yeah. 45 minutes would be fine for me, but I need to go early, so
Okay.
I'm just.
Everybody else okay with 45 minutes?
Yeah, 45 is grand.
Fantastic. Right. I'll see you back at 1:30 then. Fantastic. Take care.
Thanks, Anne.
Bye.
Anne, I think
Yeah.
saying that you've done some research on ulcerative colitis. If you have some time, I'm working with a chap at the moment. Wouldn't mind a little bit of a chat with it if you've got some time.
Yeah. Okay. No problem.
Take care.
Take care. Bye.